So the third step, create a problem representation. And this is how we're gonna do it. Age and gender. Miss Smith is a 75-year-old woman, highly relevant medical history with multiple cardiovascular risk factors and alcohol use. Presenting symptoms with semantic qualifiers. Presenting with acute, constant epigastric pain. Then finally, the highly relevant pieces of data in the patient's story. Who is found to have SEERS. SEERS is going to summarize her vital signs in addition to her elevated white blood cell, systemic inflammatory response syndrome, tachycardia, tachypnea, fever, leukocytosis. All these will point to SEERS. Severe epigastric tenderness, a very important feature in her story, without peritoneal signs, and all elevated lipase. So this is going to be the problem representation. This is going to be the most important step, because this is going to help you adopt a framework to think. So what framework am I going to take? What framework am I going to adopt? When it comes to, it's usually easier to adopt an anatomic framework. Like, I have pain in my upper abdomen. So the logic is to think, what do I have here? What's going on here? What organs do I have? So that I can predict where does this pain come from. So the epigastric pain, the anatomic framework would work better. And for this, I can just think of the 4 quadrants of the abdomen, or even the 9 regions of the abdomen, whatever works for you. So what do we have in the epigastric area? What do we have in the epigastric area? Of course, we have the stomach. So pain here could come from the stomach, maybe because of gastritis, maybe peptic ulcer disease. It also could come from the pancreas, which is the structure that lies posterior to the stomach, like acute pancreatitis. Don't forget, this pain is an acute one. And it can come also from the small bowel, from the intestines. Maybe you have gastroenteritis or food poisoning or even bowel infarction. So these are the epigastric, the organs that we have in the epigastric region. But don't forget that also that the pain might be coming from the right side. From the right side. What do we have on the right side? What do we have on the upper right quadrant of the abdomen? We have the liver. It could be hepatitis. It could be liver abscess. We have the gallbladder. Maybe you have stones or cholecystitis or just simply biliary colic. On the left side, we have what? Spleen, maybe splenic abscess or splenic infarction. Don't forget that the pain in the epigastrium could be coming from the chest. You have a problem in the chest, and this is causing pain in the upper abdomen or the epigastrium. What could be a chest problem? Maybe you have GERD, gastroesophageal reflux disease, and maybe you have, which is very dangerous, very serious, acute coronary syndrome. Do you know that heart attacks can present with epigastric pain? Yes, so we should adopt it in this framework. What else? Maybe it's coming from a little bit lower down, umbilical, not very highly likely, like transverse colon might be. And if you want to have this framework very comprehensive and complete, you can include the right lower quadrant. Maybe it's coming from appendicitis, although commonly appendicitis will result in lower down abdominal pain. It starts around the umbilicus and then becomes localized at the right iliac fossa or the McBurney point. And maybe we have lower left quadrant, maybe coming from the colon, diverticulitis. And finally, don't forget the retroperitoneal space. It could be because of an abdominal aortic dissection. So this is the framework, the anatomic framework. Now the last step is going to be applying the key features to this framework so as we can reach a diagnosis.